I'm going to provide just a brief overview of our REACH program. REACH is a nonprofit federal HIT regional extension center dedicated to helping providers and clinics in small hospitals and other settings in Minnesota and North Dakota effectively implement and use their electronic health record. Our mission is to ensure or assure that each of our clients achieve meaningful use. REACH is a program of the Key Health Alliance, which is a partnership of Stratus Health, the National Rural Health Resource Center, and the College of St. Scholastica, which collaborates with the North Dakota Healthcare Review and the University of North Dakota School of Medicine and Health Sciences Center for Rural Health. So with that, I'd like to welcome our speaker today. We're lucky to have with us Nancy Miller, and she is a program manager for Stratus Health and is engaged in the REACH program and HIT services. Nancy has been involved in healthcare for over 10 years with experience in payers and providers, health information exchange, and patient-centered outcomes research organizations. Nancy is a certified practice facilitator and subject matter expert in care coordination. She was a content expert and executive editor of the Community-Based Care Coordination Toolkit for use across the healthcare continuum in partnership with community resources. Her current focus is on assisting clients develop a community-based care coordination program and supporting HIE infrastructure through a methodology focused on quality improvement, change management, and cultural adoption toward a team-based, patient-focused model of healthcare. So with that, I'd like to welcome Nancy.
Thank you, Angie, and I'm glad to have everybody on board, and good afternoon. This program is called Community-Based Care Coordination Toolkit, or Helping Jeremy Get His Groove Back. So some of the topics that I'm going to be covering today, first I'll give some background on community-based care coordination, what it is, looking at various models, and phases in developing a program. Then I'll talk about how the toolkit is organized and the types of tools it includes, and tips and caveats for using the toolkit. And finally, I will suggest some best practices for building a community-based care coordination program. Just a little bit about me. The first three bullets describe a little bit about my background and work in this area. I'm currently working with the Northwest Minnesota eHealth Initiative to build a health information exchange to support the accountable care model and care coordination in Northwest Minnesota. I think my interest and passion really comes from my personal experience. A few years ago, when my daughter was in junior high and high school, she was diagnosed with ADHD and depression, and I was her advocate and really was the one who coordinated all her care. At the same time, I was the primary caregiver for my parents who had multiple health conditions associated with aging. So the common denominator among all these is care coordination. This is an example, or these are two models that show where the healthcare environment has been moving from traditionally to the new environment. And we kind of all know this, but I think it's helpful to provide that context. In the traditional environment, there was that loose connection of providers who worked autonomously, and it was really left to the patient to connect the dots and provide to coordinate all the care that patient needed. But the new environment, as we all know, is one where the patient is the focal point, but that new environment really requires collaboration among healthcare professionals and others in the community, which then requires that roles are seen in a different light. At Stratus Health, we use the term community-based care coordination or community care coordination to mean a partnership among healthcare professionals, including specialists and so on, and community services and resources who are all working together to provide coordinated care in a patient-centered manner. So we're going to be using this definition throughout, and the toolkit is focused on building a program around this definition. So looking at the goals, these are also sort of obvious, but I guess I'd like to go over them with you. The first is really around the triple aim, to continually improve healthcare quality and the patient experience while reducing costs. Another really critical goal of the community care coordination is to engage with community partners as an integral part of that patient care, really operating in a holistic manner. And transforming the care delivery from a provider-centric or episodic care to a patient-centered and community-based healthcare and wellness focus. And of course, one outcome is to avoid unnecessary hospitalizations and readmissions. Providing a closed loop of information through proactive and active management of those transitions in care and tracking of referrals so that procedures can be and tests duplication can be avoided. And I think really importantly is to reduce the burden on providers by supporting patients in actively managing their own health care conditions through education, patient engagement, and preparation. So who do we mean by partners in community care coordination? Obviously, healthcare professionals are in that mix, including specialists, behavioral health, and others. But also, we're talking about community and social services needed to help support that patient's health and improve the overall quality of life for that patient. So we might be looking at nutrition services or support groups, OT, PT, dental care. Families and caregivers are all partners in the community care coordination group. This is a story that I really like to tell because it provides a real life example of community care coordination. I heard this originally when on my way to work on NPR, and it talked about a person named Jeremy Seals from Oregon who was kind of in bad shape. He was 40 years old, but he had a heart attack at 35 years old. He had congestive heart failure, nerve pain. His health was deteriorating. He had mental health issues. He was unable to hold a job, and he ended up sleeping in his car. He basically had given up. In 2011 alone, he visited the emergency department 15 times and was admitted to the hospital 11 times. Well, through the Health Share of Oregon, a care coordinator named Lisa Perlstein entered his life and helped him as one would do with all patients to help them through that medical maze. When she met with him for the first time, Jeremy complained about his wet feet. She asked him, well, why are your feet wet? And he said, I have holes in my shoes. And Lisa asked him, would you like a new pair of shoes? And so she bought him some new boots and a pillow and a warm sleeping bag, because remember, of course, he was sleeping in his car. And he was pretty suspicious and distrustful of anybody in the healthcare system, but that connection really helped solidify that relationship. And by providing him care coordination, some of the activities that she did was to schedule his doctor appointments and make sure that he got there. She helped him understand what he needed to do and communicate with his doctor. She helped him get dialysis he needed, taught him to use his medications correctly, and even helped him get passes for the local community center to shower. Eventually, she helped get him a spot in adult foster care, so he had a roof over his head. And as importantly, she taught him how to effectively communicate with his doctor. Jeremy's doctor saw an amazing change in him. And she said when he has the resources available to him and when his housing stabilized, he's actually wanting to be adherent to his medication. Again, before he had just given up. He really didn't even care anymore. But with the care coordination and the interventions, his ED visits dropped from 15 in 2011 to 4 in 2012, and hospital stays went from 11 to 3. And see here a quote from Rebecca Ramsey of Care Oregon, which is a nonprofit health plan for Medicare and Medicaid patients. It doesn't take very many ED visits, and it takes less than one hospital admission avoided to actually more than pay for the time that Lisa spent with Jeremy. I love this story, and now, of course, care coordination isn't always focused on Medicaid patients or even Medicare patients, but the concepts are still the same. So going back to that model, you see that the patient is in the center with a care coordinator as an advocate for that patient and helps him with communicating with all of these entities on the patient's behalf. So the next couple slides talk about some of the typical care coordination services, and it's important to talk about these because the toolkit helps help develop some of these services. Of course, not all programs will do all of these things, but you get the idea of the kinds of things that care coordination services entail. Certainly, maintaining regular contact with the patients during transitions of care, for example, from the hospital to the home or from the hospital to rehab. And coordinating services within the healthcare systems and with those agencies, public services and other agencies, and community and support resources, again, to support the ancillary health needs of the patient. One service might be scheduling and following up on referrals to specialty providers. And because the care coordinator has that relationship one-on-one with the patient, he or she is able to identify and address risks and barriers to care in general or even specific to that patient. The care coordinator can support patient engagement through supportive communications and goal setting and setting a personalized action plan, working with the patient to become more engaged in their own health. Along with that, promoting and coaching in self-management and shared decision-making, and facilitating access to health and wellness preventive services. And of course, depending on the licensure of the care coordinator, medication management is certainly one of those services that a care coordinator might very well be doing. The care coordinator also helps the patient to be prepared for scheduled appointments, for example, helping the patient set a visit agenda or identifying some questions for that patient to ask his or her doctor. And of course, if the patient doesn't have transportation, it doesn't make any difference if they have an appointment or not. So helping them to get those transportation services is something that's very important, especially in rural areas where there are services are spread out quite a ways. Ensuring follow-up on abnormal screening, and where there are programs that the patient might be eligible for, the care coordinator can provide enrollment assistance and perhaps even identifying financial aid options and helping them fill out forms. And another care coordination service is likely to be providing education and materials, and often in several languages, as well as culturally appropriate and supportive care. A huge aspect of coordinating care is engaging the family and caregivers to expand the patient's support system. As I mentioned at the beginning, I was the support system, so I really didn't have anybody to help me. It would have been wonderful to have a care coordinator to help me connect the dots and get the care needed and around all the services that my parents needed or that my daughter needed. And finally, another example is facilitating remote monitoring, the use of health diaries, and other health management tools. So these are some examples of some models that have worked effectively. Community-based care coordination can be facilitated by, for example, a registered nurse or a nurse practitioner, a physician assistant, a behavioral health specialist, a licensed social worker, a patient navigator, or community health worker. All of these models have worked very effectively. In one city that I worked with, one small town, there was a doctor who was moving into retirement and became a care coordinator as a stepping stone into retirement, and was a wonderful opportunity for her, and had already made the connection with her patients. Community care coordination is usually takes place within the context of an accountable care model, such as an ACO or an integrated health partnership or accountable community for health, or some sort of patient-centered medical home, or in Minnesota, healthcare home, or any other model that supports that community partnership. They all have the same goal, again, to continually improve healthcare quality and patient experience while reducing overall costs. So when setting up a CCC program, I'll just use CCC program, community care coordination, there are a number of considerations. Obviously, the patient cohort being served has to be decided at the beginning of the program. Some programs really focus on high-risk patients, those who have chronic diseases or multiple conditions, or those who have specific diseases such as diabetes, hypertension, and so on. Every area of the country or community seem to have a preponderance of some conditions that they really want to focus on. And hypertension and diabetes is one that's very common. Another cohort might be the Medicaid or Medicare patients, or those who use healthcare resources in a high utilization, so those who are quite frequently at the ED or in the hospital. And of course, the care delivery model will make a huge difference on how the program is set up, and I mentioned that previously. And payment and reimbursement mechanisms are something that obviously needs to be considered, because this service isn't free. We don't want necessarily the patients to pay for it. So how is that care coordination going to be paid for? Another consideration is the licensure requirement of the care coordinator, because that will make a difference on who you bring in for your care coordinator, what the job description looks like, and so on. Another consideration is the community capability and willingness to participate. And along with that is the readiness and commitment of leadership and staff to work within this model. Another consideration is capacity in time, resources, priorities, and competencies. Support teams are really important to have in place. A care coordinator, depending on the number of patients that that care coordinator sees, there could some support behind the scenes that non-patient facing, if you will, could be very helpful in making sure the program runs smoothly. Just recruiting patients, working with doctors and EDs and others to identify those who would benefit from care coordination, again, within the cohort that's being served. Referral tracking and follow-up is something that is kind of a behind-the-scenes thing that could be done by somebody in a support role, along with appointment scheduling and follow-up and so on. Another program consideration is the quality metrics and reporting that are required either by the federal government or the state or even the ACO, whatever mechanism is funding the care coordination. There will always be metrics and reporting requirements that need to be considered. And then, of course, the infrastructure. So building a CCC program follows a general sequence or phases. Again, just like building any program, the overview I'm really relating to the preparation. So becoming familiar with the basic concepts and terminology, what resources are out there and so on. The assess piece looks at the current environment and assesses the readiness to build such a program. The planning phase looks at the models, goal setting, the organizational and program management types of activities. So planning what the program itself, where the design is looking at the structural components of the program, such as resources